Hypotonic hyponatremia results from excess retention of water relative to sodium. The causes are best understood by examining how the body handles water excretion and the role of antidiuretic hormone. This classification helps nurses link laboratory findings with the underlying mechanism. Rather than relying only on clinical volume status, hypotonic hyponatremia is best classified by the kidney's ability to dilute urine and the presence or absence of ADH activity. This approach provides clearer insight into why hyponatremia develops. Hypotonic hyponatremia can arise even when kidneys are functioning normally or when ADH remains persistently active. Understanding these broad groups allows nurses to anticipate causes based on clinical context and laboratory patterns. Primary polydipsia occurs when water intake exceeds renal excretory capacity. Although ADH is suppressed and kidneys produce dilute urine, extremely high fluid intake overwhelms this defense, leading to dilutional hyponatremia. Adequate solute intake is essential for water excretion. Diets very low in protein and salt limit the amount of solute available for renal excretion, reducing maximum urine output and predisposing to hypotonic hyponatremia, even with modest fluid intake. In advanced kidney disease, structural and functional nephron loss prevents maximal urine dilution. Even when ADH is appropriately suppressed, the kidneys cannot excrete excess water efficiently, leading to hypotonic hyponatremia. The most frequent cause of hypotonic hyponatremia is failure to suppress ADH. This results in continued water reabsorption in the collecting ducts, despite low serum sodium and low plasma osmolality. Reduced effective arterial blood volume powerfully stimulates ADH release through baroreceptors. This stimulus overrides osmotic suppression of ADH, resulting in water retention and dilutional hyponatremia. In hypovolemia, sodium and water losses activate baroreceptors, stimulating ADH release. Water is retained disproportionately, worsening hyponatremia despite overall volume depletion. Although total body water is increased, effective tissue perfusion is reduced in hypovolemic states. This leads to persistent ADH secretion and impaired water excretion, making hyponatremia an important prognostic indicator. Syndrome of inappropriate ADH secretion is characterized by continued ADH release without hypovolemia or edema. Patients appear clinically euvolemic but retain water, leading to dilutional hyponatremia. Several commonly used medications enhance ADH release or renal responsiveness to ADH. Nursing vigilance is essential when initiating or monitoring these drugs, especially in older adults. Endocrine disorders can mimic SIADH by increasing ADH secretion or reducing cardiac output. Pulmonary and systemic infections also stimulate ADH release, making evaluation of underlying causes essential in unexplained cases. Certain conditions alter the body's sodium set point or combine excessive water intake with impaired excretion. Differentiating these causes is clinically challenging but critical for appropriate management. Please like, share, and subscribe, and leave your questions as comments.